Hello and welcome. My name is Cassidy Avila with the Center for Optimizing Rural Health, and I will be your moderator. We have an excellent webinar for you today. Our topic is increasing net revenue with an accurate charge master and charge capture. So as we go through the webinar, if you have questions, please do feel free to type them into the chat box, and we will anonymously ask them during the Q&A. If you prefer to ask your question out loud, that's fine too. Just send us a message in the chat, and I will unmute your line during the Q&A. So before I introduce our speaker, I would just like to take a second to remind you that the application portal for the Vulnerable Rural Hospital Assistance Program is open through this Friday, November the 8th. So if you would like more information about this grant and the technical service that we provide to rural hospitals, please send us a message through the chat or look for the follow-up email that comes after this webinar. We will include a link to the application portal as well as our FAQs. So now it's my privilege to introduce our speaker, Kathy Dean. Ms. Dean is the Vice President of Outpatient Services and a Charge Master Analyst with Administrative Consultative Service out of Shawnee, Oklahoma. Ms. Dean is a certified a certified professional coder and auditor for the hospitals across the U.S. and professional services. She has over 30 years of experience in coding and billing for both hospitals and physician services. She provides consultation services for hospital outpatient coding compliance and revenue cycle analysis. Her expertise includes charge master analysis, outpatient documentation improvement, surgical classification, charge creation, and denial management. Ms. Dean performs complete charge master reviews as well as education and training on best practices to maintain charge master to support accurate and optimal reimbursement. She provides coding and billing compliance reviews and ICD-10 diagnosis training for outpatient services and medical necessity. She has received advanced training in CPT and ICD-10 coding and is a member of the American Academy of Professional Coders, the American Health Information Management Association, and the Healthcare Financial and Management Association. So welcome, Kathy, and thank you for being with us today and sharing your vast knowledge. And so at this time, I will turn the floor over to you.
Thank you very much, Cassidy. I'm so happy that you asked me to do this presentation. It is a very important subject for hospitals, and I appreciate everyone who is listening in today. You can go to the next slide, Cassidy. This is just the disclaimer. And today, for this presentation, I do have a bit of ChargeMaster 101 for those of you that are new to ChargeMaster, and I will get a bit more in-depth on maintaining the ChargeMaster and pricing strategies for those that are more seasoned ChargeMaster specialists. So not only will I go over what the ChargeMaster is and how it works, but also will provide information on best practices for maintaining the ChargeMaster on an ongoing basis, because that is so important nowadays. And I'll talk a little bit just shortly about the pricing transparency initiative and how your ChargeMaster should be posted to your website. For those of you that are new to ChargeMaster, I hope that this presentation will give you some good information to take back to your facility and help you in your day-to-day activities in trying to maintain the ChargeMaster. And those of you who are seasoned ChargeMaster specialists, again, I hope this also will give you some tips on maintaining that ChargeMaster each day. So with that said, I have been auditing and reviewing ChargeMasters for close to 20 years now, and I never get tired of it because there are always new and changing guidelines and regulations that keep that ChargeMaster alive. So that ChargeMaster is just a computer file system that includes all hospital procedures, all of your services, your devices, the drugs, everything that can be billed within a particular service area in the hospital. Many hospitals that have clinics also keep their clinic charges in their hospital's ChargeMaster system, such as rural health clinics and provider-based clinics. The ChargeMaster is a list of charges that the hospital makes every day in every department. So it is extremely important to keep those charges up to date and accurate and that pricing looked at so that we know what is going out on those claims and how we're getting paid for those charges. And next slide, please. So the core group of data elements that are typically in your chargemaster system are the charge numbers, which is what we enter into the system in order to get a charge to drop to the account. The revenue codes are the codes that will designate the service area for that particular service, like something that is performed in the emergency department will be assigned to revenue code 450, such as a bedside procedure. GL numbers are our general ledger numbers to map to the correct revenue center or revenue department. CPT and HCPCS level 2 codes are also assigned in the chargemaster for outpatient services. We have billing and or charge descriptions. Some facilities will have both. And then we want to try to make those charge descriptions as descriptive as we can, but as you know, there's limited characters we can enter in, sometimes only about 42 characters. So it makes it really hard to enter a description for a CPT or a HCPCS code that's like a full paragraph description. So there's a setback to some of those. So we have to come up with good descriptions. The charge amount, that's our price that we've entered in the chargemaster for a particular item or service. Our department numbers that map back to the specific departments like ED and operating room, respiratory. Modifiers can be hard-coded in the chargemaster depending on what the modifier is and what it's being used for. We generally don't hard-code the distinctive modifiers, such as modifier 59. However, if you have two of the same service entered into the chargemaster, one with a 59 and one without, then that might work. But we'll talk a little bit more about modifiers later. And then volume or utilization is what shows us how many times within a particular time period that charge has been entered or charged onto an account. Next slide, please. So the key element in the charging and billing and claims cycle that really produces the revenues for the hospital is the chargemaster. So, of course, it is really important. It is how we get paid at the hospital and how we get those charges out on our claims. There are a number of different systems that affect and are affected by the chargemaster. Our billing and claims generation, there wouldn't be any billing or claims generation without our chargemaster system. The financial management and productivity reports, those the reports that show us either on a quarterly or monthly basis how we're doing as far as our revenue and reimbursement, our cost reports and our cost to charge ratios. CMS sets our cost to charge ratios. And if you're a critical access hospital that gets paid a percentage of charges, then you have a specific outpatient cost to charge ratio, which is how you receive that percentage of payment for that particular charge on your claim. We also have to consider coding, general accounting, and there are the dynamic and static charge masters. So some of our items might be soft-coded, some of our charges, and then the HIM coding department is the one who is entering the actual CPT or HCPCS code, and then it mirrors up with the charge that's entered from someone else. So we have to make sure that we're entering the correct charge that'll mirror up with that soft-coded HIM department code. And then, of course, it affects general and cost accounting, our cost and pricing data, and our Medicare or other managed care contracts through other commercial insurances. And then our reimbursement and payment tracking and denial tracking. We must review those at least on a monthly or quarterly basis and have a good way to run that report for your denials so that you can see if they're generated by an error in the chargemaster or a coding or a department type error within the charge. So if your denial system will not generate you a good report that has the actual outpatient CPT and HCPCS codes on it, then you kind of have a setback there on what you really can drill down and see where those errors are at. Next slide, please. So the chargemaster is always changing, and mainly it's because of the CMS guidelines, the Centers for Medicare and Medicaid Services guidelines, all the coding requirements that we get from the AMA and other coding official guidelines. CMS has their quarterly updates and annual updates to CPT, special considerations for filing claims, and then department procedure changes. If you've got lots of procedures, new procedures that are changing, or you're adding to specific departments, then you're going to have changes to your chargemaster. Also, you know, not all insurances want the same thing on their claims, depending on revenue codes or even CPT and HCPCS codes. So those are the special considerations for filing claims. Next slide. So the process of a complete review, the total assessment and implementation of the changes for a chargemaster is a major project. If you have ever had a chargemaster review, which I hope you have, then it is something that is going to help with education. There's meeting with departments. I know when I go in and do a chargemaster review, one of the first things we do is the chargemaster department meetings. So we meet with each department of the hospital and start going over their chargemaster, asking questions. And so that is how you determine when things are either missing or need to be changed in the chargemaster. And of course, the understanding of what the chargemaster is and how it works through the various service areas of a hospital requires combined abilities of people from a number of different areas. You know, a single person is not going to have the knowledge of every single area in the hospital. Next slide, please. So the chargemaster contains all those entries for all the services and procedures within every different service area. Even when I go in and do chargemaster reviews, I don't have expertise in every single area. So that's why I have to meet with the departments and ask questions, go over the charges, ask some, you know, whys and whats, and if things are missing. But the best way for a hospital to maintain and to keep their chargemaster up to date is to implement a chargemaster team. You may call it a revenue integrity team or a revenue cycle team. Lots of different names are out there. I kind of stick to just chargemaster team. But that is, it's going to take multiple service areas and multiple expert staff members to help with the chargemaster. A single person is not going to be able to do it by themselves. Next slide, please. So used to, many years ago, back when I started reviewing chargemasters, and I would go on site, and usually the chargemaster was the sole responsibility of a person. That person generally was just the data entry person. The departments would, you know, request certain things to be set up, and then sometimes the departments would be able to get in and change the charges and things. Nowadays, it's not quite that way. Usually there is one or two people who make the changes in the chargemaster, but with the interpretations and of the regulations and all the coding and billing rules now, all the federal regulations, that pretty much changed over the last several years. And now we go with the team approach. That's kind of our current methodology. And you can go to the next slide, please. In that team approach, that brings in multiple staff members that have expertise in different areas, such as finance and reimbursement, patient accounts, the HIM department for coding, compliance, the clinical representatives even, and then, of course, the chargemaster specialist or coordinator. Next slide, please. All of these folks are going to bring in their specific expertise and, you know, help with keeping that chargemaster maintained. Now, the primary team is usually the CDM coordinator, someone from the business office or finance, the coding department, IT, someone from administration, most possibly the CFO, someone from compliance, and then your extended team are going to be your other service areas, managers or directors, like from lab or chemotherapy, outpatient surgery, ED, those different areas that you would bring in. Next slide, please. The CDM team responsibilities are, of course, going to be to keep abreast of the new and changing regulatory and those contractual issues because there are so many. With CMS, their quarterly updates, their transmittals that come out daily, the Medicare Administrative Contractors, coverage policies, those types of things, we have to keep up with those because they do affect our charges and our charging. And the way we're able to charge for those and whether or not we're going to get paid for a service or not. We have to assess how those new and changing regulatory issues are going to impact our chargemaster. Of course, in October, the new CPT codes came out. There's over 100 and something, like 169 or 167 new codes that the departments will need to be looking at to see if those are any services that they do or if there's some deleted codes that are going to be replaced with new codes. The HCPCS Level 2 codes will be coming out soon, within the next week or so. The OPPS final rule has already been published last Friday for hospitals. And so these are things that are going to affect our chargemaster and that we have to get implemented prior to January 1 before those claims start going out and get rejected if we don't have everything up to date in our chargemaster for the new, deleted, and revised codes. So these are just a lot of the things. Your team is going to develop policies and procedures, hopefully, for your charging processes, maybe in multiple different service areas, but for sure to have a charging policy on maintaining the chargemaster and how that is done. Next slide, please. I do have a chargemaster maintenance policy. If any of you would like to have a copy of that example policy, then I'd be happy to email it to you. I know my email is on one of the last slides of this presentation. And so if you want, you can email me and I'll email it back to you. And that would be a good start for you if you don't already have a policy. So the CDM team objectives are going to be to facilitate accurate billing in compliance with the Medicare guidelines. We always try to follow the federal guidelines with our charging and coding and billing because they're the ones that give us the most guidelines. We want to improve consistency and accuracy of charge capture processes, reduce the number of claims requiring manual intervention. If you're a biller, you know how hard it is to get a clean claim to go out the door the first time because of all of those outpatient code edits. And identify opportunities for operational improvements for best practices, and then put them on paper, have a policy. Next slide, please. The team resources, make sure you have the claims processing manual that CMS puts out, the publication 100. There's a 100-04 and a 100-02, which is your benefits policy manual. You want to make sure that you know those policies and those manuals. The national coverage determinations are on the CMS website. And then also Addendum B is our hospital fee schedule. Even if you're a critical access hospital, you must be using Addendum B because it has the status indicators for each of the CPT and HCPCS codes on them, and that will help you maintain your chargemaster appropriately. And I'm going to go over those status indicators in just a little bit. And then the National Correct Coding Initiative Manual, you must have that downloaded on your desktop at least once a year. It's only updated in January each year, and anything that's updated will be in red font. So it's really easy just to go out and download the new manual. And that's where a lot of our CMS charging, coding, and billing references are at for the bundling edits, those CCI edits for our charges. Our MACs have Part A newsletters monthly. I recommend you're on the listserv for, if you're in Texas, that would be Novitas, is our Medicare Administrative Contractor. They have LCDs, that's the local coverage policies. You must know those for your facility and which ones affect your charges. Other things would be your CPT and HCPCS Level 2 code books, having the UB04 editor that has all the revenue codes and the crosswalks and the guidelines. And then, of course, comparative pricing and the Medicaid and other payers that you may have some rules and regulations on. You've got to keep up with all of that. Next slide, please. So we're going to review and update our charge masters annually. You must. There's no way around it. With all of the changes that come all the way from, you know, it seems like from April through the first part of the year. In October is when our CPT codes come out. December is when the HCPCS level, or November is when the HCPCS Level 2 codes are published. Then we have to make sure we're adding, deleting, and revising, and then reviewing. You must have internal audits, whether you're doing it yourself or whether you have an outside company looking for you. You must know what's going out on your claims and if it's accurate or not. If you don't know that, then there's no way for you to be able to fix it on the front end, so you don't have to keep fixing it on the back end. That's the hard part. So like in January, pick 10 accounts for surgery. In February, radiology. And when I audit, of course, with the full medical record. I get the itemized statement, the UB claim form, and then the detailed payment remittance. Especially if you're doing post reviews, those things are very important because you've got to be able to look to see from beginning to the end what's been documented in the record, what the physician orders were, what was documented as being done, and then if it was charged correctly and has documentation to support it, and then if it was paid correctly or if you had denials, and then why. Next slide, please. So again, the internal audits are very important. Like I say, you've got to know what you're charging and how it's going out on the claim. So the chargemaster is probably the single most important system in the hospital in terms of guaranteeing appropriate charging, billing, and accurate and timely reimbursement. Like I said, it is how we get paid, how we keep our doors open, so we must know what's there. A lot of times I'll go to facilities and if I'm doing just a regular coding and billing audit, I'll ask, when was your last chargemaster assessment? And sometimes no one can tell me when the last one was. Sometimes they'll say 5 years, 10 years, 3 years, 2 years. But if it's been more than 3 years, that is too long. You must have your chargemaster looked at usually at least every 3 years to have a complete review. And then you must have it looked at annually or look at it yourself so that you know exactly what's going out and whether it's accurate or not. Next slide, please. So the reason I'm always talking about the Centers for Medicare and Medicaid Services is because they give us the most guidelines to follow, and they give us the most civil and monetary penalties when we don't follow their guidelines. They're always looking at us. The MAC, the RAC, the OIG, the ZPICS, all of those are the federal auditing entities, and they're always looking to see if we're doing things appropriately and if we're submitting acceptable charges. And Medicare says it's an acceptable charge if it's medically necessary, if it's safe and effective, generally acceptable medical standard, not experimental or investigational, and it's FDA approved. Next slide, please. So if you're meeting all of those guidelines, then they're saying that would be an acceptable charge. There are many ways to capture our charges in the hospital manually, such as through the use of a charge slip, like paper, electronically, such as with order entry or scanning, and then task-driven or documentation-type charges, where once the nurse or physician finalizes documentation, it actually drops a charge for that particular service. I don't see a lot of paper manual charge slips anymore, but I was just at a hospital last week doing a complete chargemaster review, and multiple departments brought in paper charge slips to their meeting, and so I got copies of those. And anytime the chargemaster is changed, next slide please, you must change any type of manual charge slip or order entry systems, those types of things, because if the paper charge slip doesn't match what you've changed in the chargemaster, it can cause then charging errors and incorrect reimbursement. So that charge sheet should link appropriately with the chargemaster entry so that the service or procedure performed is the service or procedure charged. And I have found that to be problematic before, where the incorrect charge number was on a charge sheet or the incorrect code, and so the incorrect charge was sent out on the claim. Next slide, please. Ensure a change request. I call them chargemaster change requests. Paper is preferable, but it's that way you can keep copies of those for a certain amount of time. But if you're using an electronic or email, then I do recommend you have a way to see when the chargemaster change was made. That way, if there's any errors, you can go back and see the timeline for that. Just making sure you're keeping that information for a while in case there is errors. Next slide, please. So we have several systems that would have to interface appropriately, like our pharmacy module or the order entry system. They all have to interface correctly. When pharmacy charges change, then CDM charges should change. A lot of times I see where the pharmacy module is a separate module from the chargemaster system, and when I do a review for those facilities, I may not even see the pricing in that chargemaster because that is generated from the pharmacy module. So just ensure that you're looking at some of those claims that are going out the door and ensuring that those pharmacy charges are accurate. Next slide, please. So review your revenue codes that require CPT and HCPCS codes attached. That is something I do with my chargemaster reviews. I have an analyzer that I use. I use the Optum Chargemaster Expert Analyzer, and it will tell me which revenue codes require, in other words, on the claim, a CPT or HCPCS code. So in other words, your claim won't go through the scrubber unless that revenue code has a CPT or HCPCS. So make sure if you're having problems with that in billing, that billing is communicating that information back to the chargemaster specialist so you can look to see what codes are missing or if you have an incorrect revenue code in the chargemaster. Do not add codes or modifiers without appropriate approval. In other words, to bypass edits. You want to make sure that the documentation supports. And so like for distinct modifiers like the 59 and the XEPSU modifiers, there must be orders and documentation of the services provided to support those charges that are triggering those edits before you can put those modifiers on. So if you don't have access to the medical record, you shouldn't be assigning distinct modifiers. So just ensure that on those charges that are coming across, you know for sure when to bypass and edit and when it would not be appropriate. Do not bundle charges that have CPT or HCPCS codes attached unless required, because as you know, there are some commercial insurances that don't want certain charges on the claim or CPT or HCPCS codes, or they want different revenue codes, or they want something rolled in. There's always something special that somebody wants that we have to comply with in order to get paid. And that's never going to change unless we get a uniform system where everybody has the same rules and regulations. Make sure all line items on the claim have charges. I know, CMS said a long time ago for surgical, we could have the bulk charge on the primary code, and then any other CPT code charges could have the zero. But, that may only work for Medicare that pays by APC payments. If it's another insurance that pays by line item charges from a fee schedule, if there's no price on there, then you may not get paid for that particular service. So you just want to make sure, even with Medicare and other payers, I would recommend having a price or a charge on every line item on that claim that you're expecting to report cost on or get payment for. Next slide, please. And then reimbursement. Know how you're getting reimbursed, such as with Medicare. Inpatient is paid by MSDRGs for Medicare. Outpatient is paid either by an APC payment or a cost-based payment. Lab services are paid from the laboratory fee schedule. If you're a CAW, a critical access hospital, in the outpatient setting, you're receiving a cost-based payment, but in the inpatient setting, a CAW receives a per diem, per day payment. So know what your payments are. In some facilities that have the outpatient physical therapy and occupational therapy and speech, they get paid from the Medicare physician fee schedule if you're an OPPS hospital. If you are a critical access hospital, then you are paid a percentage of those charges on outpatient claims. Next slide, please. So it's important to know your reimbursement and how you're being paid, whether it's in the inpatient or outpatient setting, and by particular insurance carriers. So our coding systems are CPT. There's multiple different categories of CPT in the CPT book, CPT 1, 2, and 3. So we have to look at those categories, and each department should be looking at their new revised and deleted codes for the new year. Next slide, please. And getting ready for that, and then relaying that information back to the chargemaster specialist. The CPT codes include multiple different service areas. It could be anything from anesthesia to medicine. There's drugs in the medicine section for vaccines and immunizations. There's pulmonary, respiratory services, radiology. All the different service areas in the hospital is covered by CPT codes. Next slide, please. Our CPT book, I get the professional CPT code book. I recommend that the departments either are able to review their CPT codes online or in the book in their section. I know when I go to facilities, not every department has a CPT code book, but one should be available to them, especially at this time of the year, so that they can go through the book and look at their new revised and deleted codes. So they can make an informed decision on what needs to be changed in their particular department of the chargemaster. Next slide, please. And then does everyone understand the symbols in the book? New codes, revised codes, those are pretty easy. But the add-on codes and the bundled conscious sedation and things like that, may not apply to every department. So I would recommend that the coding department, if there are some departments that don't understand, then you need to educate them. Next slide, please. This is what the book looks like as far as the CPT code. These were new codes a couple of years ago, and 76641 is for a breast ultrasound. This is the complete code, but then when you drop down to 76642, it says limited. Well, if you don't know how to read the primary and the child codes, I think we call them parent codes and child codes, then it would be very confusing to look up CPT code 76642 and it just says limited. You're not going to know what that means. So you have to read to the semicolon in the parent code and then drop down and read the child code. So the departments need to understand how to read those descriptions in the CPT code book, just because sometimes there are multiple child codes underneath a parent code, and they won't make sense if you don't read that first code to the semicolon and then drop down and read the child code. Next slide, please. HCPCS Level 2 codes are created by Medicare and a couple of other insurance carriers. And again, they cover all departments in a hospital. It could be anything from ambulance to drugs, laboratory, infusion services, devices, DME, all of those different areas. Next slide. So again, it's very important to have a HCPCS Level 2 book in your facility so that the departments can look at their new revised and deleted codes even on an ongoing basis. Of course, we have to get quarterly updates. That book, the HCPCS Level 2 book, is good at the beginning of the year, but then we start getting quarterly updates starting in April, and so then we have to go to the CMS website to get those updates. And this is the website that you go to. And drugs, the pharmacy, they should be looking every quarter at the updates. And usually there's not that many, maybe 5 or 10, but they need to be looking at their quarterly updates because that's what CMS likes to update the most are the drug HCPCS codes, such as the J codes. Next slide, please. This is the email listserv that you can get on so that when Medicare does post those quarterly updates, then they will send you an email. Next slide, please. And then the outpatient code edits. This is the website for the integrated OCE specifications. And this is where you can go look at all of those outpatient code edits to see what new ones are out there each quarter or at least at the beginning of the year. Next slide, please. Addendum B is our APC hospital fee schedule. So our OPPS hospitals should be looking at this to see what the national payments are for our codes, what the status indicators are, and you critical access hospitals also, even though you're not paid an APC fee schedule payment, these codes, CPT HCPCS, are assigned to status indicators. Next slide, please. And each status indicator is going to tell us whether or not that charge or that code is billable within a hospital setting, whether it should be on the hospital charge master, whether it's going to be paid or not paid. And this is the website where you go to download Addendum B. And of course, since the codes are updated quarterly, the HCPCS code, so is Addendum B. Next slide, please. But this is one of the main ways to maintain your charge master and ensure that the correct codes for hospital technical component billing are in your charge master. This is an example of what the Addendum B hospital fee schedule looks like. It has the code, a short description, the status indicator, if there's an APC number, what the relative weight is for that APC number, the payment rate, which is the national payment rate, and then the unadjusted copayment. Next slide, please. But those status indicators are what tell us whether or not that code is for hospital use, whether it's for physician use only or another type of facility. And so what I did was I listed out each status indicator, their alpha and alphanumeric, and I said yes or no as to whether or not I should see a code that's assigned to that status indicator in a hospital charge master for technical component billing. Because for physician, professional side, that's the professional component. And then, of course, if you do have some professional services that you're billing for your physicians, that's fine. Those codes can be in that section of the charge master. They just can't be in the sections for your technical component. So as you can see, B status means no, that is a physician or other type of a provider, and it may have an alternate code. Maybe Medicare has created a HCPCS level 2 code for that particular service, and we can't use the CPT code, but we can use the HCPCS code. So I put this in here for you because I use this day in and day out. Even my Optum Charge Master Analyzer, when I run a Charge Master through it, it automatically assigns the status indicators to those codes for me. So it's very easy for me to go through and look. Next slide, please. And look at those status indicators to see if you have any B status or M. If you see an M status code, let's say you're setting up a new charge for a department. They have requested a CPT code to be added. Well, if it's an M status and you know you're billing for the technical component for that department, not for the physician, then that is not the correct code for the hospital to be using. And so it's very easy for me when I'm doing a charge master review to go through and pick all those out and know that that should not be in that section of the charge master. Next slide, please. And so this is just to help you out, next slide, to be able to start using these status indicators. Now, you didn't receive a toolkit. I usually am on site when I'm doing this presentation, and I provide a toolkit. But if you want a copy of my status indicator key, which combines the CMS status indicator key along with an additional description to help you understand what each one of the status indicators mean and how it's used in the hospital, then I will email it to you. If you just email me, then I will email that status indicator key back to you. Next slide, please. This is where you download the actual CMS status indicator key that goes along with the Addendum B. Next slide, please. CMS does tell us that even though a CPT or a HCPCS code may say physician in the description, doesn't mean that it is only used for a physician. Next slide, please. That it can be used by the hospital. Many times now it will not just say physician, it will say physician or other qualified healthcare professional. The only way you're going to know whether or not a CPT or HCPCS code is for facility technical component or professional component is to go look up that CPT code on addendum B and see if it's a status indicator B or an M. If it is, you need to be looking for an alternate code for the technical component if there is one. Next slide, please. The NCCI manual, I just wanted to give you the website because you need to be downloading this NCCI manual at least once a year in January, whenever it comes out with the changes in it. And each department should have their section. Each chapter is kind of linked to, like, one chapter, chapter 9 is radiology. Chapter 6 may be laboratory, those types of things. And each department should have a copy of their section because that's where their coding, charging, and billing references are at. Next slide, please. Make sure you have some key performance measures created, especially for emergency department. This is emergency department and outpatient observation are two of the biggest error service areas that we find when we're doing our audits and when I do chargemaster reviews. So make sure you're looking at the emergency department and your outpatient observation area and the charges, and ensure you're not missing any bedside procedures because those are outpatient areas and our bedside procedures are separately billable. Next slide, please. This is the EDN and bell curve. You want to know if you are elevated at level 4 like the national bell curve. Medicare says this is an accurate bell curve and that hospitals are doing a good job. So you want to match up your bell curve from your utilization stats and see if you're matching pretty closely to the national bell curve. And all of our data, of course, is always 2 years behind. So like for 2019, we're looking at the 2017 data. In 2020, we'll be looking at the 2018 data. Next slide, please. The ED procedures. Like I said, the bedside procedures are separately reportable from your ED visit. You must have documentation, of course, to support those, and no matter whether it's the physician or other qualified healthcare professional like nursing staff, those are billable on the technical component because we are billing for our cost. And so whether a doctor or physician's doing it or a nurse or other qualified healthcare professional, the hospital gets to charge for those services. Next slide, please. Documentation is always key. That's what drives our charges. So if the documentation and physician orders is not there, then we don't have anything to support a charge or can't even make a charge. So even our E&M levels are driven by documentation. Our start and stop times of infusion therapy should be documented. That's how we charge accurately. Next slide, please. And then every CPT and HCPCS code should have on the claim for payment must be supported by a physician order, and that's as stated by CMS, and then we must have documentation that it was done. Next slide, please. Ensure outpatient line item denials and non-covered charges are reviewed, and then track and trend. Like I said, you've got to have a good report, and you need to provide those reports to your revenue cycle team or chargemaster team to look at. I would recommend on a monthly basis, if not, then a quarterly basis. Next slide, please. Our outpatient code edits have about 111 edits now, and we have over 12,000 medically unlikely edits. So, there are going to be tons of claims that are going to trigger these edits, and you need to be looking at those, especially on the outpatient side, because just because the whole claim isn't denied doesn't mean you may have 2 or 3 charges or 1 charge on that claim that was denied. Next slide, please. So you have to look at those individually. So DME exempt items in your chargemaster are going to be your orthotics, like your walking boots and knee immobilizers, prosthetics, surgical device implants, and specialty dressing. None of those have to have a DME license. You can charge those to Medicare, and they will be either reimbursed separately or covered and maybe packaged into APC payments, but they are a covered service and no DME license is needed. Next slide, please. The HCPCS Level 2 codes are L codes for orthotics. Those knee immobilizers and seat collars, revenue code 274 has to be on the claim. And next slide. And I've given you just some examples of the L code and what I'm talking about here in the knee immobilizers. Like you can go through some of these, Cassidy. The next slide is the walking boot, and the next slide is a cervical collar. And next slide. So all of these have to be in the chargemaster with the L code, like for this wrist hand orthosis. And the next slide, and under revenue code 274. You should be looking at your revenue and usage reports to check your gross charges, your accuracy. Each department should be doing a charge reconciliation. Next slide, please. Every hospital, either daily, monthly, weekly, those reconciliations should be done. And look at some claims and itemized statements, as I stated before, to make sure those charges are being billed correctly. Next slide, please. Chargemaster pricing, next slide. Charges should not be lower than the fee schedules, if at all possible. You should be looking at that every year to make sure your charges are appropriate based on your cost. It should reflect cost plus markup, and then you should be comparing and doing charge analysis to your core base statistical area average charges, your CBSA, and peer charge comparisons. If you can't do that, or if you haven't purchased that information, I would recommend you get an outside entity to help you with that. It's very important to compare those charges, not only to the fee schedule amounts, but then also to those average charges in your geographical area. Next slide. I also recommend using your cost to charge ratio to help you look to see if you've got your charges set appropriately in the chargemaster, such as for surgical devices, blood products, and laboratory charges that come from reference labs where they're billing you for the service, and high cost drugs. Next slide, please. These are just some examples on how you would do that, like for an anchor or some type of a supply or implant, high cost. You just take the cost of the item and divide it by your cost to charge ratio. This hospital was 0.32, so their charge in the chargemaster should be no less than $4,687 for that item. And then, adding a markup to that depending on if there are other overhead costs. Next slide. Here's an example of setting a blood-specific cost to charge ratio. These are posted on the CMS website. If your hospital doesn't already have a blood-specific CCR, then Medicare has one for you, and you have to look up your provider number in the addenda, and it will give you your cost to charge ratio. And again, this is an example of how to take your cost, divide it by that cost to charge ratio, and then look at your item, whether you're creating a new charge or checking a charge in the chargemaster. This is how you would do it. Next slide. And then also for high-cost drugs, you can do the same thing to ensure, because what Medicare does is they take your charge on your claim and they multiply it by your cost to charge ratio to reduce it to cost. So this is Medicare's way of telling you you need to use your cost to charge ratio to either set devices or check your charges. Next slide, please. And then calculate any other overhead costs for handling. Next slide. And then remember that all of this affects your cost report, because that is very important. You want to make sure that your cost accountant folks are aware when you have a complete chargemaster review and when you're changing pricing or other services. Next slide. And then make sure you're billing for inpatient bedside procedures. These are procedures that aren't included in your room rates, and so you have to have a way to charge for those, either by charge documentation driven, a charge sheet, or having your coders enter those. When they actually code the PCS code for the procedure, they can actually enter the charge for the service. Next slide, please. These are the items that are paid separately outside of a DRG payment. They can be billed on a bill type 121. So if you don't know that, I would recommend that you find out how to do that, because all of these services are separately billable and can be paid separate from your DRG payment. Next slide, please. Or even your per diem payment if you're a critical access hospital. And then knowing your fee schedules again and how you get paid. This slide is telling you each one. Next slide, please. And then here's your Novitas and CMS websites for the LCDs and NCDs. These all affect our charges. And next slide, please. And then just to recap, you're going to update your CDM at least annually. You want to have a chargemaster complete review at least every 3 years, and you should have a chargemaster team and have quarterly meetings, if not monthly meetings, depending on the size of your facility. Departments should keep a current copy of their chargemaster section or be able to view it. Next slide. And make sure the department charge sheets or order entry systems correlate with the department CDM. Keep up to date with the CMS updates, transmittals, and quarterly updates, and then get your Novitas newsletters or whichever Mac you have. Make sure you're on their listserv to get their newsletter. Next slide. And then keep charging, coding, and billing tools up to date. Your reference books, and if you're using software, make sure it's kept up to date with all the quarterly updates, and then or your yearly updates, and then perform monthly billing and chart audits on yourself to determine the accuracy of your claims and payments. And I would recommend at least once a year having an outside source do a compliance audit for you. And then perform daily and monthly charge reconciliation reviews. Next slide. And then, of course, make an education for the employees part of your plan for success, because that's the only way to keep up to date is education for the hospital employees. Next slide, please. This is my contact information and my email address that I told you about. If you want those items that I referenced, then just email me and I will send those back to you. I know that was a lot of information in a short period of time. Doing an actual complete chargemaster assessment takes many days and meeting with multiple departments. So if you have questions or if you need further help, you can always contact me. I'll try to answer your questions or even can do audits for you. But with that said, I think Cassidy said there may be some questions, and so let's do that. I think we've got about 10 minutes.
Thank you, Kathy. That was excellent. So you have the ability now to type your questions into the chat box. You can also just let us know that you want to be unmuted, and you can ask your questions out loud if you prefer that. So we will give everyone just a couple of minutes, Kathy, to type their questions. We've had some inquiries as to whether or not the slides will be available, and yes, they will. We will send out the presentation, and you'll have access to the slides as well. And that will come in an email within 48 hours of the presentation. And I think we also have some expressed interest in a couple of the things you mentioned that you would email out. So you'll likely be seeing some emails coming through.
Okay, great.
Okay. So we have a question for you, Kathy. Are you aware of any critical access hospital cost report or monthly modeling projections education program?
Well, no. Every once in a while I do see some of the cost report education come out through HFMA, so I would recommend going out to the main HFMA website. That's where I see some of the most cost reporting information come out, and then sometimes every once in a while I'll get in my inbox some information, but I know there's may not be a whole lot of workshops or conferences out there for that, but I would recommend checking the HFMA website.
Great, thank you.
And by the way, I'm not a cost reporting person, so I wouldn't be able to help you with that piece of it.
Okay. Okay, we don't have any questions in chat right now, but we'll still give everyone a few minutes. We've got 5 minutes left on the webinar time. But I just want to remind you guys that Kathy is an excellent resource. So if you have questions, now is the time. Here at the center, we get a lot of questions about chargemaster from the hospitals that are in our year 1 program. So this is just a great opportunity to ask those questions and get some answers. Okay, so we do have a question in chat. As a critical access hospital, we have limited funds. Do you know of any financial assistance programs for chargemaster review and training?
Well, I do know that several of our critical access hospitals that have had us come in and do chargemaster reviews did apply for grants through some federal programs and got money through that. But now your rural health, your state rural health contact may be the one to see who or where you would send those applications for those grants. If you want, I can give you, if you email me that question, I have got a few hospital contacts that I could give to you that have actually gotten the grants, and maybe you could contact them. I would let them know that they might be contacted and find out how they did it.
Oh, I think they would love that. That would be excellent. So I will make sure that you get in touch. This question was sent privately, so I'll make sure you guys get in touch after the webinar. Thank you for that offer. It was very kind. Okay. The next question. Oh, I think it may be just a response for that person. There are state-sponsored, federal-sponsored programs. We've used SHIP and Flex grants to help with chargemaster reviews, at least in Utah. Thanks, Tyler. Thanks for offering that. Yeah, definitely. I know there's programs out there. That is not something that I have ever done for a hospital, but I do know that when we've gone in and they've told me that they have received some federal funding or grants, and so I know it's possible. Yeah, for sure. All right, guys, we have 2 more minutes left on the clock if anyone has a last-minute question. We still have quite a few people on the webinar. Okay, well, I will go ahead and kind of do a thank you and close, and we'll still leave the chat open. But thank you again, Kathy. That was really excellent and very informative. We will send the recording and a short 60-second survey out after the webinar, as well as the technical assistance grant application information that I talked about at the beginning of the webinar. So if you'll just take a second to open that survey, that would really help us out. Just let us know e-spot or let us know what you would like to hear from us in the future. We're always looking for ideas and ways to help support you guys. So thank you for joining us today. And with no further questions in the chat, I guess we will go ahead and close up. So thanks, everyone. Have a great day.